If you are over 60, there is one medical procedure you might face that carries a silent risk. One that has nothing to do with the surgeon's scalpel or the condition being treated. It happens without any pain, without any warning, often while you are in the safest place you could possibly bear, the operating room. You go in for a routine hip replacement, a heart valve repair, or even a minor procedure, feeling anxious but prepared. You trust the doctors, you followed all the instructions. And the surgery is a complete success. But when you wake up, something is different. The fog does lift. Weeks, even months later, you find yourself struggling to find the right words. Your memory, once sharp, now feels like a sieve. You get lost driving to the grocery store you've been going to for 30 years. Your family tells you it's just the anesthesia wearing off, or you are just tired, give it time. But in your heart, you feel a quiet terror that a part of you that went to sleep didn't fully wake up. As a physician who has dedicated my life to the health of seniors, I have seen this subtle, heartbreaking tragedy far too many times. It's not a complication you will see discussed in dramatic TV shows. It's a quiet epidemic known as post-operative cognitive decline, or POD. And it happens because the very magic that allows for painless, modern surgery anesthesia interacts with an aging brain in ways we are only now beginning to understand. It's not about the skill of the anesthesiologist. It's about the unique physiology of a brain that has lived a long and full life. Today, I am going to pull back the curtain on what really happens when a person over 60 goes under anesthesia. We will talk about the profound difference between this state and simple sleep, why your brain is more vulnerable, and most importantly, the concrete, evidence-based steps you can take before you ever enter the hospital to protect your mind. This isn't about fear. This is about empowerment, because the conversation about a safe surgery, especially after 60, doesn't end with your heart and lungs. It must begin with your brain. To truly understand how to protect your brain, we first need to dismantle a common myth. Anesthesia is not sleep, not even a very deep sleep. Comparing anesthesia to sleep is like comparing a controlled demolition to a house settling at night. Both involve the structure being quiet, but the underlying mechanics are worlds apart. When you sleep, your brain is incredibly active. It cycles through elegant, predictable stages, like a well-rehearsed orchestra. It's consolidating memories, clearing out metabolic waste. It's a busy, restorative workshop. But under general anesthesia, your brain isn't just resting. It's being intentionally and systematically disconnected. Imagine your brain is a massive, bustling city. Consciousness is the hum of millions of conversations happening simultaneously between different neighborhoods, the financial district, talking to the creative arts sector, the residential areas communicating with the transportation hubs. Anesthetic drugs don't just ask the city to be quiet. They act like a pharmacological force that shuts down the communication infrastructure. Drugs like propofol, one of the most common intravenous anesthetics, work by enhancing the effect of a neurotransmitter called GABA. Think of GABA as the universal calm-down signal in your brain. Propofol essentially floods the city with this signal, telling every neuron to relax and stop talking to its neighbors. It's like cutting the phone lines and shutting down the internet service for the entire metropolis. Suddenly, the different parts of your brain can no longer integrate information. The thalamus, which acts as the city's main switchboard operator, routing all incoming sensory information sites, sounds, touch, is effectively put on an extended coffee break. So even if your ears still technically hear the surgeon's voice, that signal never gets routed to the parts of your cortex that would make you consciously aware of it. This is why you have no memory of the event. It's not just that you were asleep. It's that the very mechanism for forming new memories, the hippocampus, was also taken offline. There was no one home to record the minutes of the meeting. This state is what we call a pharmacological blackout. It's a reversible, controlled coma. And while this is a medical miracle that allows for incredible life-saving procedures, it's also a significant event for the brain, especially a senior brain. Now, why does this pharmacological blackout pose a greater risk to a brain over 60? The answer lies in a concept we call cognitive reserve. Think of your cognitive reserve like a financial savings account you've built up over a lifetime through education, social engagement, and mentally stimulating activities. A younger brain has a large, robust savings account. If it encounters a major, unexpected expense like the metabolic stress of surgery and the network disruption of anesthesia, it has plenty of resources to draw upon to recover and get back to normal. It can bounce back quickly. However, as we age, our cognitive reserve naturally declines. Our savings account may be smaller. It doesn't mean the brain is damaged. It just means there's less of a buffer. The connections between neurons might be a bit less efficient, and the brain's ability to repair and re-establish communication networks after a disruption is slower. On top of that, older adults are more likely to have a low-grade, chronic level of inflammation throughout their bodies. Surgery itself, the act of cutting tissue, is a form of controlled injury that triggers a major inflammatory response from the immune system. This is a normal and necessary part of healing. But when you combine this wave of inflammation with the already existing chronic inflammation in an older adult, and you add the disruption of anesthesia, it can sometimes create a perfect storm. This inflammatory storm can temporarily make the blood-brain barrier a protective wall that shields your brain from harmful substances in the blood more permeable. Inflammatory molecules can sneak through, causing further disruption in the brain's delicate environment. It's like having a minor plumbing issue in an old house versus a new one. In a new house, a small leak is an easy fix. In an older house, that same small leak might cause significantly more damage because the infrastructure is simply less resilient. This is the biological basis for post-operative cognitive decline. It's not that the anesthesia damaged your brain. It's that the combined stress of the surgery and the anesthesia overwhelmed your brain's ability to bounce back to its original state of function. And understanding this is the key to prevention. So, if you or a loved one is facing surgery, what can you do? This is where you shift from being a passive patient to an active participant in your own care. The preparation for protecting your brain begins weeks, not hours, before the procedure. And it starts with a conversation. The most important person you will interact with on the day of your surgery, apart from your surgeon, is your anesthesiologist. This is not just the person who puts you to sleep. They are, for all intents and purposes, your personal intensive care physician for the duration of the operation. They are the pilot of your life support system. You have the right and the responsibility to have a detailed pre-operative consultation with them. I want you to write these questions down. First, given my specific health conditions, mention your heart condition, diabetes, lung issues. What are the specific risks of cognitive changes for me? And what is your plan to mitigate them? This question signals that you are informed and concerned about your brain health. Second, will you be using a brain function monitor, like a BIS monitor, during my surgery? A bispectral index BIS monitor is a device that uses sensors on the forehead to measure the electrical activity of the brain, giving the anesthesiologist a real-time indication of how deep your level of anesthesia is. While not necessary for every case, for older adults or those undergoing long surgeries, it can be a valuable tool to help avoid giving too much anesthetic medication, which has been linked to a higher risk of delirium and POCD. Third, what is your strategy for post-operative pain management? This is critical. Aggressive use of opioids and certain other pain medications after surgery can contribute significantly to confusion and delirium. Ask if they plan to use a multimodal approach, which involves using a combination of different types of pain relief, such as nerve blocks or non-opioid medications like anti-inflammatories, to reduce the overall need for narcotics. This simple conversation changes the entire dynamic. It places your cognitive health at the forefront of the anesthetic plan. And if this information is resonating with you, if you are finding this valuable, please take a moment to click the like button. It truly helps the channel and ensures this vital information can reach more seniors who need to hear it. Beyond the crucial conversation with your anesthesiologist, your physical preparation is paramount. Let us talk about the big three: nutrition, medication, and exercise. First, nutrition. For at least 2 weeks leading up to your surgery, your body needs to be a fortress of nutrients. This is not the time for restrictive dieting. You need to focus on 2 things: high-quality protein and anti-inflammatory foods. Protein is the building block for tissue repair. Seniors already struggle with sarcopenia, or age-related muscle loss, and surgery accelerates this process. Aim for sources like lean chicken, fish, eggs, beans, and high-quality protein shakes if your appetite is poor. The second part is fighting inflammation before it even starts. Load your diet with colorful fruits and vegetables, rich in antioxidants. Think berries, leafy greens, and bell peppers. Healthy fats from avocados, nuts, and olive oil are also powerful anti-inflammatories. Think of it as preloading your body with the fire extinguishers it will need to handle the inflammatory fire of surgery. Next, medication. You must create a comprehensive, detailed list of every single thing you take: prescriptions, over-the-counter drugs, vitamins, and even herbal supplements, and bring it to your pre-op appointment. Something as seemingly harmless as ginkgo biloba can increase bleeding risk, while St. John's wort can interfere with how your body metabolizes anesthetic drugs. Be brutally honest. Your anesthesiologist needs this complete picture to prevent dangerous interactions. They will give you specific instructions on which medications to stop and when. Finally, exercise. Unless your condition prevents it, do not become sedentary in the weeks before surgery. Even gentle, regular walking does wonders. It improves your circulation, strengthens your heart and lungs, and makes your body more resilient to the stress of the operation. Better physical fitness going into surgery is one of the strongest predictors of a better outcome, and that includes a faster cognitive recovery. It ensures that your brain is receiving robust, oxygenated blood flow, which is its best defense against the challenges to come. Now, let's walk into the day of the surgery. UV prepared. UV had the conversation. The moment arrives, you are wheeled into the operating room. It's often bright, cold, and filled with more people and machinery than you expected. This can be intimidating. Here's a small but powerful tip: bring a sense of calm with you. Practice some deep breathing exercises as you wait. Remind yourself of your preparation. This isn't just happening to you, you are an active part of this team. The anesthesiologist will place monitors on you and a keg for your heart, a pulse oximeter on your finger for oxygen, a blood pressure cuff on your arm. Then, they will likely start an IV in your hand or arm. They might tell you they're giving you some relaxation medication first. This is often a benzodiazepine like Versed, which has a powerful amnesic effect. This is a kindness. It means that even if you reawake for another few minutes, you likely want to remember the anxiety-provoking moments just before you go under. Then comes the main event. They may ask you to breathe oxygen from a mask for a few minutes. This is called pre-oxygenation. It fills your lungs and blood with a reserve of oxygen, a critical safety buffer. Then, they will say something like, "Okay, I'm giving you the medication now." You will start to feel sleepy. This is when the propofol is administered through your IV. It works incredibly fast, usually within 30 to 60 seconds. You might feel a slight burning sensation in your vein. You might be asked to count backwards from 100. Very few people ever make it to 90. There is no gentle drifting. It's more like a light switch being flicked off. One moment, you are aware of the ceiling tiles. The next, you are not. There is no perception of time passing. To you, it will feel as though the surgeon hasn't even started. This is the time travel we spoke of. And during this period of no time, your anesthesiologist is not on a coffee break. They are right there, by your side, monitoring every single breath, every heartbeat, every subtle change in your physiology. They are constantly adjusting the levels of anesthetic gases, fluids, and medications, making hundreds of micro-decisions to keep your body in a stable, safe balance while the surgeons do their work. It is a testament to the incredible skill and vigilance that this happens millions of times a day, safely. Waking up is not like the movies. It's not a sudden gasp back to reality. It's a gradual, often confusing, re-emergence. The process begins when the anesthesiologist turns off the anesthetic gases and stops the intravenous medications. Your body then begins the work of metabolizing and clearing the drugs. The first sign of waking is often the return of your own spontaneous breathing. As you start to breathe on your own, the breathing tube, if you had one, will be removed. This can cause some coughing or a sore throat, which is very common. You will then be taken to the post-anesthesia care unit, or PACU. This is the recovery room. A nurse will be dedicated to you, monitoring you closely. And this is where the brain's reconnection process can get a bit strange. The city's communication systems are coming back online, but not all at once. The first thing you will likely notice is a profound sense of grogginess. You may feel disoriented. You won't know where you are or what time it is. Your sense of time will be completely scrambled. It will feel as if only 5 minutes have passed since you were in the operating room. Some people experience vivid dreams or hallucinations as the brain tries to make sense of the jumbled signals. It is also very common to feel emotional. You might cry without knowing why. And yes, this is when you might say some unfiltered, embarrassing things. The part of your brain responsible for social inhibition is one of the last to reboot. Please be kind to yourself. The recovery room nurses have truly heard it all. They are not judging you. Their only concern is your safety. They will be asking you to take deep breaths, checking your pain level, and making sure you are stable. The most important thing you can do in these first few hours is communicate your needs clearly. If you are in pain, say so. If you are nauseous, say so. Managing these symptoms effectively is the first step toward a clear-headed recovery. In the days and weeks following surgery, you and your family need to be vigilant observers of your cognitive function. Post-operative delirium is different from the short-term grogginess in the recovery room. Delirium is a more acute state of confusion that can fluctuate, coming and going over several days. It's more common in older adults, especially after major surgery. The patient may not recognize family members, may be agitated, or may be very lethargic. It is crucial to report this to the medical team immediately. Delirium is a medical emergency, and it is often caused by treatable factors like infection, electrolyte imbalances, or reactions to medications. It is also a strong risk factor for the longer-term post-operative cognitive decline. For POD, the changes are more subtle and persistent. This isn't about blurting something out after waking up. This is a sustained change in your ability to think, concentrate, and remember. Your family may notice it before you do. They might say you are repeating stories, forgetting appointments, or struggling with tasks that used to be easy, like balancing a checkbook. If this happens, do not dismiss it. It is not a normal part of aging, and it is not something you just have to live with. The first step is to see your primary care physician for a thorough evaluation to rule out other causes. They can perform baseline cognitive tests and refer you to a neurologist if needed. The good news is that for many people, these cognitive changes do improve over time, often within 6 months to a year. But recovery requires proactive steps. Gentle physical activity, engaging in mentally stimulating hobbies like puzzles or reading, maintaining social connections, and ensuring a nutrient-dense diet are all crucial for helping your brain rebuild its connections. It's a process of rehabilitation, just as you would rehabilitate a new hip. And I encourage you to share your story. If you or a loved one has experienced this, please consider sharing your journey in the comments below, with kindness and respect. Your experience could provide immense comfort and validation to someone else who is feeling scared and alone. So, let's bring this all together. Is anesthesia dangerous for seniors? Modern anesthesia is one of the greatest medical achievements in human history, and it is remarkably safe. The risk of a major life-threatening complication in a healthy individual is incredibly low. But for those of over 60, the conversation needs to be more nuanced. It's not just about surviving the surgery, it's about thriving after it, with your mind and spirit intact. The risk is not that you wake up. The real, and far more common risk, is that you might wake up changed in a subtle way. But this risk is not a foregone conclusion. It's a challenge that we can meet with preparation and knowledge. By understanding that anesthesia is a controlled, reversible coma, a temporary pharmacological hijacking of your brain as communication network, you can appreciate the importance of building your resilience. By strengthening your body with nutrition and exercise, you create a stronger fortress. By having a detailed conversation with your anesthesiologist, you make your brain health a priority in the operating room. And by being vigilant about cognitive changes after surgery, you ensure that any issues are addressed quickly and compassionately. We have moved beyond the era of simply asking, "Is it safe?" to the more empowering question, "How can we make it safest for me?" It's about respecting the wisdom and complexity of an aging brain and giving it the support it needs to navigate one of the most significant challenges it may ever face. Thank you for taking the time to understand this incredibly important topic. If this video has provided you with clarity and a sense of empowerment, please consider subscribing to the channel and sharing it with a friend or family member who may be facing surgery. Your knowledge is your power. I will see you in the next video.